Thank you. Oh, about 25, 30 years ago. What? More closer. Oh. I took a fall skiing, and they said, oh, I was bleeding. I said, no, don't move. No. They came and they put me on a board, and they took me to the hospital. And my good friend, Dennis Cirillo, who was actually the head of the hospital medical staff way back then, and was also a cardiac surgeon, plastic surgeon, and a general pain in the ass. I told my wife to call him, and my nose, I kind of pulled all the skin off my nose with my glasses. But they did an x-ray of my head, and they go, ooh, what's that? And it was, a brain tumor. And it was a cavernous angioma on the pons. Anyway, so my friend Dr. Shalin said, go see Dr. Winn. He was, he knows everything. And so we would go back and forth to New York in those days, and I went and saw him. And I sat down in his office, and we kibitzed for an hour. Then he said, okay, and then he says, yeah, you got it, don't worry about it. I think that was basically it. And so, I went and saw another specialist that they sent me to, and he also said, he was like a real German guy. Well, I will operate on Tuesday, and but you will only be paralyzed for 2 or maybe 3 weeks, and then maybe you'll be able to walk. And maybe not. But anyway, so that was the exciting part. So Dick Winn and I got to be friends, and he's a very bright guy, has all these credentials, and I don't know what else to say other than here's Johnny.
No, I want to take the microphone away from you. Okay, well, thank you very much for coming. Thank you to the Wintermans for their hospitality. Thank you to the congregation, the rabbi. And thank you to Barbara and Gil for their hospitality also. Much appreciated. Well, in the service, it used to be the tradition they could turn out 90-day wonders. And there's a considerable shortage of neurosurgeons in the United States. So the goal here for all you students, which I look around, I see nothing but students, is to turn you into at least the beginnings of a neurosurgeon. Well, except for Richard, who is a very accomplished neurosurgeon and bicycle fanatic. So here's what I'm going to try and cover. We should be done by 7 or 7:30 after the extensive comments by Larry. We're going to cover the job description, how to become a neurosurgeon, personal journey, past, present, and future, or what's new in neurosurgery. So what's the job description? And the question is neurosurgery synonymous with brain surgeon? So let's see here. Here's I'll give you a little.
Yeah, something soft, I'm driving. Parking's an absolute nightmare around here, isn't it? You have to reverse into the tiniest of spaces. Still, I managed it. Parking's not exactly brain surgery, is it? And I should know. Careful, I'm a doctor. I'm a brain surgeon. Big difference. Big difference. Yeah, I actually know a joke about this. What's the difference between a doctor and a brain surgeon? One's not exactly brain surgery, the other is brain surgery. So, what do you guys do?
I'm an accountant.
Oh, that's good. Yeah, I can do without an accountant. Putting in those tax forms can get really confusing, can't it? Still, it's not exactly brain surgery, is it? Brain surgery, believe me, is very complex. Are you an accountant too?
No, I work in charity.
Oh, that's a very selfless job, isn't it? I really admire you. I don't think I could ever do what you do. I say that because it's emotionally draining, not because it's hard. I mean, it's not exactly brain surgery, is it? Which, as a brain surgeon, is what I do.
I know who to drink. I was a brain surgeon, you know. Yeah, you mentioned it. Oh, Jack, have you been late to the Space Centre?
So, Jeff, how do you earn a crust?
I'm a scientist. I work mainly with rockets. So, pretty tough work. What do you do?
Well, I don't mean to boast, but I'm a brain surgeon.
Brain surgery. Oh, it's actually rockets.
So, notwithstanding the video, being a neurosurgeon is not synonymous with being exclusively focused on the brain. So what is the neurosurgery territory? And since the nervous system extends all over the body, we're really the last of the general surgeons because your nervous system is all over your body, as you'll see subsequently. Here's what we do. Brain tumors and the spine tumors, vascular disease, stroke, spinal disorders. And what many people don't realize is that 70% of neurosurgeons, and I guess, or approximately 70% of what neurosurgeons do is related to the spine. So that means degenerative spine disease, which I suspect, looking around, most of you at least have it, even if it's undiagnosed, and many of you perhaps have had it and had intervention for it. Spinal tumors, spinal vascular formations, spinal pain, deformities, and all of these the treatment has dramatically changed in the last 30 years because of the use of instrumentation. In some ways, you need to be an engineer now to be a spine surgeon because it's so complex dealing with these instrumentations that are associated with stability. And then there's trauma, head and spinal trauma. Trauma, at least under the age of 20, was the number one, and above infancy, the number one killer and maimer in that age group. Infections, meningitis, abscess of the brain and the spine. Pituitary disorders, such as tumors causing decrease and increased function of the pituitary gland. So the question is, in your minds, what is the pituitary gland? And this shows the pituitary gland. It lies under the brain, and it has control of all the glands in your body, including your thyroid, kidney, lactation, bone growth hormone, a variety of other entities. It is the master gland, and I'm not going to say too much more about pituitaries in the neuroanatomy part of my talk, but it's divided into two sections. There's the adeno-pituitary, which is connected to the brain through a vascular transport system, and then the posterior pituitary, which is actually linked by neurons into the brain. So it is clearly the master gland. Then there's disorders of regulation of the fluid that surrounds your brain, and that can build up and cause hydrocephalus, or water on the brain. And most of you probably associate with this entity to something that you might see in an infant or a child, but at the other side of life, it's not that uncommon to see in an elderly person who has had the so-called low pressure hydrocephalus, which neurosurgeons will treat with shunts, where you put a tube into the collecting system and run it down into the peritoneum. Then there are functional disorders. And functional disorders would include epilepsy, depression, obesity, and movement disorders. And this has been much in the news recently. Over the last, I would say, 30 years, there have been some very dramatic changes in advancement and significant expansion in the field related to deep brain stimulation, which I'll present towards the end of my talk. Then there's a whole peripheral nerve disorders. And you probably wonder, wait a minute, you mean carpal tunnel? Well, yes, carpal tunnel, that's all the domain of neurosurgery. And then another important concept that a neurosurgeon must master is neurology and endocrinology. And the neurosurgeon has to discern variations in these entities which can simulate a surgically treatable disorder. Because after all, you in the future, when you're out next week practicing neurosurgery, don't want to operate on a patient who doesn't have a neurosurgical disease, but a neurologic disease, such as multiple sclerosis, giant cell arteritis, and Alzheimer's. And the question comes up to me and others, does anything change in neurology and neurosurgery? And look, here's the latest issue of the JAMA, which probably has one of the most momentous advances in medicine, just came out 2 days ago. And that is, there's been the development of a highly accurate blood study to diagnose Alzheimer's disease. It's a very difficult entity or disease to diagnose definitively. And in the past, neurosurgeons were often asked by neurologists to do brain biopsies to confirm or rule out the possibility of Alzheimer's disease. So now it looks like there's a high probability there's going to be a blood study that can tell whether a patient has Alzheimer's form of dementia. So if you need to, at least, I mean, this isn't a gut course that I'm presenting here. There's going to be some reading, and here's, if you want to go into detail, here's a textbook. My wife's going to be out in the lobby. We're going to have a reduction in the price from the usual $1,200 for this 5,000, the most recent one, 4,800 page book. And I'm prepared to autograph it. So what is the territory of neurosurgery? You've heard a little about it, but we're going to begin now the first part of Neurosurgery 101, neuroanatomy, because you do have to understand the territory. If you want to drive from here to Denver, you need to know how to get there. If you're going to operate on someone's brain, you need to know the anatomy. You don't want to operate on the wrong part of someone's brain. You want to be in the right territory. So the neuroanatomy, what's the central nervous system? It consists of the brain, the spinal cord. That's what the CNS, or central nervous system, is. And then there's the peripheral nervous system. And I hope you can see this, but the peripheral nervous system is actually bigger than the neurosurgery, the central nervous system. Here in yellow are the peripheral nerves, whereas the central nervous system, as I said previously, just consists of the brain and the spinal cord in pink. There it is, better. Great. And I'll just play back the tape. And here's the central nervous system in pink, the brain and the spinal cord. And then the rootlets coming out of the spinal cord are the beginning and source of the peripheral nervous system. And you can see it in yellow. Okay, let's drill down a little into what constitutes the brain. And the brain commonly is made up of the cerebrum, which in turn is broken down into 4 lobes. There's the frontal lobe, the parietal lobe, which is behind the frontal lobe. The eyeballs, nose is out here, back of the head is here. Parietal lobe, occipital lobe, and temporal lobe. So that's the brain, as you probably see in some murder mystery on TV. But the brain consists of the hindbrain also, the cerebellum, which coordinates motor movement. So if my elbow is the axis and I pull my forearm forward to my shoulder, I am actually giving direct orders to my bicep. It's a conscious effort, right? Boom. What I'm not thinking of, which is not in the conscious realm, is I have to also relax my triceps. Because if you don't have that coordination, I could strain, but the biceps is not going to relax. So that motor coordination all occurs unconsciously in the cerebellum. Again, cerebrum up here, cerebrum up here, cerebellum here. Okay. Then there's the brainstem. So the brainstem contains all the outflow and inflow from the spinal cord going up to the cerebellum and the cerebrum. It also contains the cranial nerves. Cranial nerves. So the cranial nerves are located in the brainstem, and they are the sensory and motor control of your face, hearing, stability. The cranial nerves are 12 in number, and really the first cranial nerve doesn't involve the brainstem, nor the second brain. The first one is smell. It's the most primitive of our cranial nerves. And the second cranial nerve is vision. So that's all occurs in the brainstem. And also in the brainstem is what we would call vegetative activity. Now I know, looking out there, that all of us have been accused of misbehavior, and I will not point at the person who might accuse me, for example, of misbehavior. And I always say, it's a vegetative activity that I forgot to pick up my dirty laundry or something like that. But vegetative behavior is, the best example is breathing. I can voluntarily take a deep breath, but just think about it. You do not consciously think about breathing, right? Okay, everyone out there, take a deep breath, and then boom, you let it out, but you're not thinking about breathing 12, 15 times a minute. That all occurs in the brainstem. That's the vegetative center. It also contains other things such as blood pressure, coordinates blood pressure. And then lastly, the spinal cord. Okay, that's one last thing about neuroanatomy, and then you'll be soon ready to go out there and start operating. The brain is divided into two hemispheres. There's the left hemisphere and the right hemisphere. And many of you have probably heard about, this person's left hemisphere, meaning ascribing a certain political position to the brain, or ability to see beauty when looking at something. But I'm not going to get into that. But you need to know there's a left and right hemisphere. Now, what does that mean? Well, it turns out, if we look at the body, okay, the right side of the body is in red, and the control of my right side comes from my left hemisphere, okay? And the left side of my body is controlled by my right hemisphere. So it's cross-wired. That's important. So if someone comes into your office and says, I can't lift up my right arm, do not operate on the right side. This is the side you want to be. You need to know the territory. Okay, that's it for anatomy. I don't know how many of you took an anatomy course, high school, college, and you were happy to have it end. Well, it's over. Now we get to something more complex, neurophysiology. It's function. That's what physiology means. And the central nervous system has two basic functions. Sending signals out of the brain. So that's motor, best example, motor control. Move this finger. I mean, I'm not thinking, well, I have to be conscious and think I can move the finger. That signal arises from the left side in my motor cortex. I'm going to get to the motor cortex in a bit. And if I want to move my left index finger, it comes from the right side in the motor cortex. And then the second function is sensory function. So that's receiving signals back to the brain. So for example, if I touch my index finger, that signal's going up through the peripheral nervous system, up the spinal cord, through the brainstem, boom, and is interpreted in the left hemisphere in the sensory region of the brain, the parietal lobe, and vice versa on this side. So we'll have to dig down into this a little bit deeper. So here's a picture of the left hemisphere. Here's the nose, which we call anterior, and posterior, back of the head. And this illustrates in blue the motor cortex. That's called the primary motor cortex. So that's where hand function, tongue, facial function, movement is there. Sensory function is in the parietal lobe, in the anterior parietal lobe, and that's somatosensory cortex. So just to put it in context and what you've seen already, so here's the frontal lobe, here, and then that contains the primary motor cortex, and then there's the sensory area, which is in the anterior part of the parietal cortex. Now it's a little bit more complex than that. Here, in fact, is the brain is divided into thousands of little receptive areas in which interpretation is formed or facilitative movement occurs. It's not so quite simple that I say move this finger. There's a signal that goes through many areas of the motor cortex. So, for example, the associated motor cortex that's here, and that then relates to the primary motor cortex, which then sends the signal, as I described, down through the spinal cord, out through the peripheral nerves, the muscles innervating this finger. And the same applies for the signals coming back into the sensory motor cortex. Here, it has to be interpreted by the associated sensory cortex. Now here's a fascinating bit. Here, the people drawing this diagram, which represents the sensory cortex, not in this audience. So they just assumed they would put these words in for thigh, thorax, neck, shoulder, tongue, and it looks like the thigh cortex is as large as the finger cortex, okay? Same size, but that's not the way it is, fortunately. So if you look at this is the sensory cortex. This is the motor cortex. And you can see that the hand area, especially the first finger and the thumb, number of neurons that receive the sensory input from your fingers and thumb, much larger territory in the brain. And the face, especially the lips and tongue, much larger. So I want you all to put your fingers together like this, so you have your two nails, and touch your index finger like that. You can feel 2 points, right? If not, I will see you after the, okay? You can feel 2 points. Now turn your hand and touch the back of your hand. Can you touch? feel 2 points? No, you can't discriminate as well. Well, maybe, okay, put it in your forearm. I know Gil Scharf is giving me a hard time as he always, no. But then touch here. Well, guess where you're really sensitive? On your lips, okay? And that means that in your brain, your finger, your thumb, enormous area that allows you to discern 2 points, millimeters apart, whereas the back of your hand, tiny area. And that's shown in this picture. So if you wanted to draw a picture, it would be very distorted from what you see when you look at someone. Look at the hand, huge. Look at the face, huge. And that's why it's related to the neurophysiology. Now, here's a demonstration by a well-known classical pianist. Now look at that hand function, seriously. It's truly amazing, right? Okay, there's the hand function. I know Larry wants to see it again and get up and dance, but I'm not, it's got to be later. I'll just show it. Okay, now let's see how he plays the piano using his feet. Even with his shoes off, he could not manipulate those chords as well as with his fingers. And that's, if you look at his cortex, his motor cortex, or your motor cortex, it's huge for hand and much smaller for your toes, because you can't do the same functions with your toes that you can do with your hands. Well, I don't think so. Okay, so that's it for motor and sensory. What about language? Language is it's called eloquent it's contained in the eloquent cortex. It's really some of the most complex functions that humans perform. It used to be thought we're the only people who could communicate, but as you probably know, recently it's been found that elephants can communicate to a rat off the human audible scale. It's very deep, and it's been known for several decades that porpoises can communicate with each other through sound. Whether it's a true language, it's unclear, and I suspect it's going to take decades more to unravel that. In any event, right-handed individuals' speech function is in the left hemisphere. And that's called left hemisphere dominance. And you should get to know some of this lingo, so when you're seeing patients, they don't think, well, this guy doesn't understand lingo. All right, so right-handed, 90% of the population end up with speech located in here in the temporal and frontal regions. So, boom, left-handed. Now, right-handed. Now let's take left-handed people. Well, it turns out that only 50% of left-handed people have speech in the right hemisphere. Huh? You're thinking, what? Well, it turns out that's because left-handed people as infants were trained to use the right hand. So if you go and then you'll find out who's really true left-handed dominance. Even if they say, no, I'm a right-handed hitter, no, it's all related to training. So it's cross, just like with movement and sensory, it's a cross relationship. Okay, so much you've done with your introduction to neurophysiology and neuroanatomy. Let's look at something that's unique to the brain, and that's the regulation of cerebral blood flow. But let's look at general cellular physiology. Activation of any cell, any activation means it's working, consumes oxygen and glucose. And oxygen and glucose must be replaced or the cell will become non-functional. So, you know, if you don't have blood flow to your brain, it ain't gonna work after that. And replacement, let's assume physiologically rather than pathophysiologically, replacement occurs via blood flow. And the blood flow has to be well organized and highly efficient. Otherwise, the body will spend a huge amount of energy in order to replace very specific in the brain requirements to keep various small areas of the brain working. And this shows the anatomy. Most of you perhaps know this anatomy already. You can see that this is the anterior cerebral vessels, middle cerebral, and then the posterior cerebral vessels. But these are not the vessels that are tightly regulated. And I would put it in the concept of Amazon. If Jeff Bezos organized Amazon in the following fashion, he'd be out of business within a week. And I'll give the example. I, as a customer, want to order one book, let's say The Rise and Fall of the Roman Empire. And I send it into Amazon, and Amazon does not have a specific way. They send out 330 to 330 million people in America one book, The Rise and Fall of the Roman Empire. Well, that is a highly disorganized system, and they would be out of business within a short time. Instead, you need tightly regulated components in the brain to replace the oxygen and glucose that's utilized in a very small area of the brain. So let me give you an example in an experiment we did. And this will be done, it was done in a rat, anesthetized, respirated, temperature controlled, and then we stimulate the sciatic nerve to simulate touching of the hind paw of the rat. Then on the contralateral side, because remember the brain is cross-innervated, we make a craniotomy, opening in the skull, put a piece of glass, cover glass, and we then bring a microscope down, and this is what it looks like. We bring the microscope, on the microscope, we bring it out to a video timer and recorder, and then here's what we see under the microscope. In white is the brain tissue. The darker vessels are the veins draining the brain, and in highlighted, and really not that dark, are the arterioles, which supply blood to the brain. Now, I'm going to show you these arterioles, which end up supplying thousands of small areas of the brain, but are regulated to supply blood to those areas of the brain that's working. I mean, I'm looking, some of you look like you're nodding off. I have news for you. The brain still works when you're sleeping, so stay awake. Okay, so I'm gonna show you a 40 micron, and I compare it to the human hair, 20 to 200 micron vessel. Now, here we go. We stimulate the contralateral sciatic nerve. This is the arterial. It's about 30 microns. Vein. Boom. We start stimulating that nerve. There the blood vessel dilates. Look at this one. Large blood flow, then going specifically to sensory hind limb cortex. All right? And not only must, if you're on top of your game, you're regulating the delivery, the supply and demand of blood containing the oxygen and glucose. Not only must you get the blood there in a timely fashion, but when the demand goes down, the vessel has to go back to resting size. So I'm going to show it to you one more time. I hope I am. There we go. So again, look at this vessel right here, is hardly visible. Okay, boom, we start stimulating. And that's because the brain is activated in a very small area. And then we turn off the stimulation. And the vessel starts to go back to its resting state. And this next slide shows the incredibly small area of the brain that's activated. This is the area of the brain that's activated. That's about 0.5 millimeter in size. And it's only this area, that's the area that you saw the blood vessel going to. So it's a very important concept that the brain, think about it, the heart is just, I know this may come as a surprise to some of you, it's really a dumb piece of meat. And it just beats like that, and it just gets, all at once. The whole heart needs to have blood come in because it's working, pumping. But the brain, I hope your brain, much more unique and elegant. Touch the finger right here. Just in this area of the index finger cortex, glucose, oxygen consumed, boom, and you gotta supply it. Okay, now we're gonna get into an even more sensitive area relating to how to become a neurosurgeon, demographics, and manufacturing of neurosurgeons. Where is the neurosurgery faculty? So here's the training required: college, medical school, 4 years, residency, 7 years, fellowship for some people, 1 to 2 years. Demographics. I know we have some retired neurosurgeons in the audience, so they may want to comment or throw tomatoes. So here's the distribution of total active physician in largest specialties. This is in 2010, but the most recent data really hasn't changed that much. And where are the neurosurgeons? Way down here, 5,000, which is an overestimation because they included people in training. You'll see that drops down. So in 2010, there were 3,700 practicing board-certified neurosurgeons for 5,700 hospitals serving 311 million people. There's a significant geographic maldistribution, 1 per 66,000 in Alaska, and 19,000 for one neurosurgeon in DC. Larry said, when I showed him this, he said, well, that's not surprising. The people in DC really need help. Aging population significantly increases the conditions needing attention by neurosurgeons. Technology has vastly expanded, and I would say the entire aspect of medicine. Think about CT, MR, ways of making diagnosis has expanded the patient base and the diagnostic possibilities. Earlier retirements of neurosurgeons have decided, screw it, I'm not happy doing this. I'm going to pull the ripcord. So, and I'm going to spend a few minutes on regulatory and training exposures, which have constrained the numbers of neurosurgeons, and in fact, almost all specialties in America. Here's 2008 to 2020 for all specialties. Here's the demand, and here's the supply, and neurosurgery's in the red line. Now, how did this mismatch come about? Well, one of the ways is, hi, we're from the government, and we're here to help you. Came about. Here's an example. The Gemini report, President Carter assembled a group of experts, quote, experts, in the field to determine how to control an increasing cost of healthcare in America. And he assembled this panel of both government experts, insurance experts, learned deans and vice presidents of medical centers, and they studied the problem and they identified, among other things, as economists had done previously, that doctors were the key part of the rising costs. And why was that? Because after all, you don't get into the hospital unless a doctor sends you into the hospital, and hospitalizations can account for a significant component of the rising costs, number one. Number two, doctors again at fault because they write the prescriptions for the very expensive drugs. So the Gemini committee of all these experts concluded that in excess of approximately 70,000 physicians will exist in 1990. And faced with the future surplus, Gemini recommended that the U.S. medical schools decrease their enrollments by 10% relative to the previous level. What they were unable to see, of course, was the innovations coming down the pike, which have increased almost logarithmically. I would have had the privilege of spending time in training at Atkinson Morley's Hospital in Wimbledon. That's where the CT scanner was designed. Hounsfield won the Nobel Prize for that. And that, as I said, greatly expanded what we could do. So is the shortage for physicians still in existence? Absolutely. Here's 2017 in the JAMA, and here's in July of this year. Where are all the pediatricians? It's a real deficit to provide care for the increasing population and increasing ability to make diagnoses and new types of treatment. So, you know, when the wall fell, Soviet state fell apart, Soviet planners in 1980, they lost their job. And as you'll see in further comments, but American medical planners in 2024, they're still on the job. And the members of the Gemini committee, they made a wrong diagnosis. If you, when you're out there practicing, or me, say, oh, we're gonna operate on the left side of the brain, but it's really on the right side, you're in trouble. Not the members of the Gemini committee. They went on into even more exalted jobs in government and in universities. And of course, when it really became evident that there was a shortage of physicians, they were retired. People didn't even remember their name. I will reveal their names at a later time, okay? Okay, how are manufacturing neurosurgeons? Here's the factory. It's all located in universities. The locations, 102 universities have residencies, and they produce about 160 residents per year. What's the supervision of the training programs? What is the supervision of the factories? It's all controlled, in essence, by the American Board of Neurological Surgery, which specifies the number of residents that can be trained in each program and the elements required. So you have to do X number of brain tumors, Y number of spinal tumors, and so forth. And on a regular basis, the programs are examined and receive either disapproval or approval or conditional approval to continue training residents. And I was program director and chair of the Neurosurgery department at the University of Washington for 20 years. And in those 20 years, I saw the increasing complexity of the oversight by these boards. What's the constraint on production of residents? Well, first of all, as the consumer, I mean, I'm a consumer as well as a neurosurgeon. You want the highest quality of neurosurgeon or pediatrician for your kids or grandchildren, right? And the quality, as I said, the limitations are related to case volume and academic productivity. What about the finances? The average cost to train a resident, 7 years, is about 1.2 million, and I suspect it's higher. I put these slides together some time ago. That's covered in part by Medicare. So academic medical centers receive a supplement to their patient care for education. And that is what supports the residents' education, and also, to some extent, a small amount to support the salaries of the teaching physicians. Then the Balanced Budget Act came along and kind of looked at the Gemini report and said, we're not giving any more money. So they've restricted the amount of money to support residencies. What about the supply chain? It's limited by the number of graduating MDs. And although the production of MDs by medical school, after people came to the realization that the Gemini report was wrong, has expanded, but nevertheless it has not matched the growth in the population. And then we come to duty hours. Now this is somewhat complex. Boom, okay? Duty hours. I think Larry may have slipped that into these slides. Yeah, I blame you, Larry. So duty hours, it used to be there were no restriction on the number of hours that a resident could work. In those days, I used to say, well, we were ships of wood and men of iron. It's unsafe to say something like that, but I thought today I could express that feeling. So there was major concern, mainly about patient safety. There was one bad case in New York City at Cornell. Unfortunately, it was a daughter of a newspaper person who then, exposed the whole reason why his daughter had a problem, and it was related supposedly to the fact that a resident had been up for 36 hours. So there was a massive change in the regulations for how long a resident could work in New York, the state of New York. And in addition, there was concern about work-life balance. And that was related to the fact that increasing burnout in residents, suicide rate, divorce rates, and interestingly, divorce rates and suicide rates varied by specialty. So mainly outside of the surgical disciplines, and the surgical disciplines were usually the residents who were in the hospital the longest. And there was also the thought that by restricting the hours that the residents spent in the hospital, when they went home, they would study more and do better in the in-service exams. I thought that was a little naive, if you think about it. But any event, sadly, these changes occurred, which restricted duty hours, so that residents in the middle of an operation they won't be wearing a watch because you can't wear a watch at the operating room. They'll say, I'm sorry, my hours are up. Boom. And they'll leave the operating room. Because if they don't do it, the program will get penalized, the hospital will get penalized, and boom. So but sadly, none of the benefits that have been promised have occurred. So again, American medical planners, they're still on the job. Okay, let's look at a few cases so you'll feel comfortable when you do your first craniotomy. So here's a 44-year-old with new onset seizures, right frontal, non-enhancing mass. You can see, now here's an MR scan. And just to confuse things, MR scans on this particular cut reverse everything. So the right hemisphere is shown on the left side and the left hemisphere on the right side. I show that because I think those of you who are still awake would ask me, wait a minute, Dr. Winn, no. It's just, that's the convention. So what you see here, let's look at, here's the normal cortex of the brain. So this is a gyrus, and this is a sulcus. Gyrus, sulcus. Look over here, it's all obliterated because there's a tumor in there that's expanded and collapsed the soul side. And here now is the same patient, but with a sagittal cut. So it's like, boom, this way. And you then look like an orange, cut it, look like that. That one, you cut it and look like that. Okay, so here's a different signal that's used, same scan, but the interpretation is different. And again, here's, you can see obliteration of the soul side in the gyri, all right? And again,
Where's your pointer?
vegetative state. And again, okay, so now comes the tricky part. Now I'm gonna cut this short because I saw Gil get up as he was falling asleep. And let's go back to the neuroanatomy. Here's the motor cortex, sensory motor cortex. What do we have? So the motor cortex is probably right here, sensory cortex here. We say, okay, we can take all this out and not hurt the patient. And we're going to show you. So here's the actual, in the operating room, we do a craniotomy. Okay, we expose the right side of the brain, the frontal lobe, probably back here, the parietal lobe. Here's the midline, nose, anterior, lateral, ear, posterior. All right? And we assume the motor cortex is here, motor cortex, and here is the sensory cortex. But we can prove that in the operating room because you don't want to make a mistake. And what do? We take this electrode, which can sense sensory input to the brain. So we will stimulate the fingers. The anesthesiologist can just rub them, or there's electrical way. You put something around and, stimulate. And what we find is sensory cortex. You can't see. See 6, 5, 4, 3, and 2. That's where sensory cortex is. And we know because we've studied neuroanatomy, the motor cortex is here. So we say, okay, as long as we stay about here, it's safe. He's not going to wake up paralyzed on the right side. And boom, here's the tumor out. The motor cortex is here. Sensory cortex here. Here's the tumor out, and the patient goes on his way. Let me just cover 2 more things. Cerebral aneurysms. What's the cerebral aneurysm? Outpouching or sac of the artery, which has a propensity to burst. Aneurysms are a pretty lethal entity. There's about a 50% mortality overall when an aneurysm ruptures. And if the patient survives the first hemorrhage, high likelihood that the aneurysm will bleed again. And so 50 years, actually beginning in about the late 40s, cerebral aneurysms could be occluded by doing a craniotomy, tracing it out, as you'll see in the subsequent slides, seeing the aneurysm, carefully defining the neck, putting a clip and removing it from the circulation. And here are a variety of different clips that neurosurgeons invented. Here's a drawing in which, again, nose, we do a craniotomy. Here's the frontal lobe, temporal lobe. We carefully split it apart. This is done by a famous medical illustrator, Netter. His operations were always done bloodless. but it usually in reality doesn't happen that way. And when you finally get the temporal lobe shown here, pulled away, and the frontal lobe pulled away, you see the carotid artery coming in here, and this is the region where most cerebral aneurysms are located. So let's see what the reality. Here's the patient. That line is where we make the skin incision. We do a craniotomy. That means taking the bone out, opening the covering of the brain called the dura, and here we see it. Here's the temporal lobe. Here's the frontal lobe, which you now are experts on. We go down here. We see the carotid artery here, the optic nerve going to the right eyeball, and this is the view that Netter drew. You can see one optic nerve, other optic nerve. Somehow it's on a timer. And here's the anterior cerebral artery here on the right, the left, and the aneurysm's up here, just like right here. So here's the aneurysm. This is an unruptured aneurysm. If it were a ruptured aneurysm, we would never expose the whole aneurysm. We would leave the brain covering like that, because if it bled, like from this blood, it forms a scar, and as you pull the brain away to expose the aneurysm, kaboom, the aneurysm ruptures, and it's a real problem. So here's a clip, boom. So just to bring you up to date, surgery for aneurysm was the only option. There's a better option, or an equal option, and that's closing up the aneurysm by not doing a craniotomy. But what the neurosurgeon, neurologist, or neuroradiologist, they feed this catheter all the way up through the aorta, up the carotid artery, into the brain, and they fill the inside of the aneurysm up with these coils, okay? And by applying a very low voltage, they separate the catheter from the compact coils, and the aneurysm then is no longer a threat to the patient. I don't know if you can see it. Here's the aneurysm before coiling. Here it is after. These are the coils, and that eliminates the chance that the aneurysm is going to rupture. It's 6:12.
Questions?
I just heard it from, I see the hook. So maybe I'll stop and be happy to answer any questions. Table mate from last night, or lunch.
A quick question. I understand that you can treat an aneurysm with lasers. Could you comment on that? Like with the lasers? Or is that false?
Don't think so. If that's what you're going to recommend to your patient coming in to see it, do you have a lawyer?
I think I need one.
Yes, ma'am. Oh, yes, sir.
Earlier in your talk, you talked about the language area of the brain as a single area. When you look at people who have reading problems and you do functional MRIs, you see 3 and maybe in the case of dyslexia, 4 areas. Why do you think that language has 1 area but reading has 3 or 4 areas?
You know, language is, as I suspect you know, based on your question, highly complex. One of my former residents is the chair of neurosurgery at Iowa. He operates on a lot of awake patients, and almost every month they're finding new aspects of the physiology of both speech and reception. So speech is really the motor concept, whereas hearing and then interpretation is the sensory component of speech, to put it in that structure. And so, you know, when I go like this, you know, I could say, it's kind of sharp. If I had something high, I mean, I would interpret it different. And so even in the more simplistic sensory areas and motor areas, when it comes to speech, it's infinitely more complex. I mean, think about what is required to speak. Turns out your respirations, you have to be able to regulate your respiratory effort, your vocal cords. Also, I mean, you're talking about millimeter difference in the way I can articulate a word. That's all under neural control. So it's not surprising that the complexity of speech is more diffuse than the more simple sensory or motor areas of the brain.
I specifically talked about reading. Could you comment on that? Or maybe it is.
No, I mean, reading is considered part of the larger, you know, there's splitters and lumpers. It's part of language function, reading. I actually have some films of awake surgery. For example, and there's one violinist playing while awake surgery related to organization of the music areas. You may think it's, you know, play a violin, it's really a motor function. It's not the same as me moving my finger. So language is complex. Just in last year in Nature, there was a whole revision of what was thought to be the auditory components of speech. So, you know, it's up for debate.
I have two questions for you. I am left-handed and a musician. So I'm a little worried about the fact that you said that only 50% of my right brain is taking care of my language. Where's the other part? And is that why I'm so confused?
No, I'm sorry if I said that if you're left-handed, if you're cortically, your speech is in the right side of your brain.
Yes.
But you appear to be a right-handed person. That's because early on in your life, your parents, your grandparents, your teachers said, no, do not write with your right hand.
I am dominantly left-handed and left everything.
Yeah, so you're, you know.
So you weren't, so I have 100% in my right hemisphere, so
Yeah.
I'm okay.
Yeah.
That's so reassuring.
I'm sorry if I confused you.
The reality is, though, you don't know until you can be tested. There's a test.
So in order to determine whether you're truly right brain dominant it used to be a WADA test where they put a catheter in the blood vessels supplying what they think is the speech area, and they'll inject barbiturate, or an updated variant of barbiturate. That puts a very small area of your brain to sleep. So they will ask you to count back from 10, and if all of a sudden you stop, then they know, your speech area is on the right side of your brain, not your left. And they can have done the same thing with speech reception also. So, but, you know, it's not like they're defining this much of the brain. It's like this much of the brain, so.
I don't think I'll do that.
No, okay. But you can recommend it to one of your patients. And, okay, oh.
I just have a question. I read lately quite a lot in a lot of different places that
Alzheimer's is now connected and being called diabetes 3. What is your comment on that? I'd be careful what you read. I mean, I think, well, it has a long, quote, incubation period, and diabetes has a long, so-called incubation period. I'm not sure that there's any connection between diabetes and Alzheimer's, other than true, but unrelated. So a lot of people have what used to be called mature onset diabetes or diabetes 2, boom, okay? And a significant number of people may have a pre-Alzheimer's condition, but it may mean those two circles interact. Doesn't mean that they're connected.
That is for diabetes 3. That's been something that we call it. Have you heard it too?
Yes, I've heard one. No, yeah, they write about it.
Well, you know, one of the persons that I've received a lot of input for 59 years frequently says, oh, I just read this. Yes.
About a couple of weeks ago, the most interesting thing I ever heard was from the hospital, Mount Sinai in New York, about the new technology that they're using for people with strokes, the people who have movement problems.
Well, you know what, I was going to show.
It's the most interesting thing I have ever heard. It's so exciting what's happening in medicine, and especially with the brain.
There's a neurologist who's putting stimulators.
You know, with the plugs that they put in your head, and trying to go through your vein. I mean, all that's, it's phenomenal.
Right. And that's achieved primarily through deep brain stimulation.
Yes.
And that was, I had a whole series related to deep brain stimulation, movement disorders, Parkinson's, essential tremor, and then you get into the treatment of obesity, addiction, all of those areas.
Stimulating the brain?
Yep, well, after all, think about it. Addiction is a brain disease.
Didn't know that.
Addiction, well, where does the craving come from? It comes from your brain. Obesity comes from your brain. So depression, deep brain stimulation, much of that work originated in Toronto, in part because Canada had more permissive regulations about doing these procedures in patients. And so Toronto has really had a very innovative approach to treating a variety of diseases with deep brain stimulation. For example, they made the observation that deja vu occurred when they misplaced one of the electrodes. They got it 1/10 of a millimeter away from where they were supposed to be. And the patient said, oh, I can see my caretaker when I was in the carriage, the crib. And, you know, the neurosurgeon said, but he insisted on it. And they went back and found the caretaker, and he described this blanket. And sure enough, that was the blanket. So the concept, you know, deja vu, you get into the neuropsychiatric aspects of brain function, which are hard hard to reconstruct. And so what it showed is these psychological phenomena have a clear anatomic basis. So maybe next time I'll go through the whole slides.
It's phenomenal when they talked about someone having a stroke and their left arm was paralyzed. They could see where in the brain and they could zap it, and that the person was able to start feeling their left arm, and or how they use robotics on your arm, making it feel like it's your own and you're able to move everything.
So here's what you're talking about. Stroke occurs in the United States at about 800,000 in the United States. Aneurysms, 30,000 per year. Brain tumors, 30,000 a year. But stroke, 800,000. And really, I'm going to present this and then I think it's time to go eat. For centuries, there was really no effective treatment for stroke. It was mainly supportive therapy, keep the blood pressure regulated, not too low, not too high. And in the 1980s, there were drugs developed that were clot busters, so to speak. And they would treat the patient with these clot busters. And they had moderate to not so moderate outcomes in patients when you're looking at hundreds of patients. And then the interventional folks, neuroradiologists, neurologists, and neurosurgeons came up with the concept of physically unblocking the vessels in the brain following a stroke. Stroke in a large number of instances occurs because either a clot flies off from the heart to the brain and lodges in the smaller vessels, or it arises off the carotid artery in the neck. And so there were multiple trials from 1970 to 2013 supported by the NIH in which they mechanically tried to grab the blockage of the vessel. Right? All of them failed. So the NIH said, sorry, we're not going to spend millions of dollars doing this again. But the investigators, the neurologists, neurosurgeons, interventionists said, we think this concept's going to work. And they developed a technique whereby they would put an umbrella, they would push through the blockage with a very small wire, and they'd have expandable umbrella that would go above where the block was, that would catch the particles that occurred when they grabbed the clot. And they did a series of tests. And this was 5 studies, 3 in the New England Journal of Medicine showed the effectiveness. It's about a 90% effectiveness, in which, as shown here, this is the, again, netter. The clots come off the carotid artery up here, and the blood just stops here in the middle cerebral. This is where hand and on the dominant hemisphere speech function would be. So here's the arteriogram, carotid artery, anterior cerebral, going up, okay. Middle cerebral, blocked off here. They go in with a catheter, which is shown here, feed it all the way up here, put an umbrella beyond where the clot is, pull either through suction or grabbing it, and then irrigating it. And look, here's the reestablishment of flow. In my professional lifetime, this is the most significant advancement, not just in the science and clinical aspect, but looking at the numbers of patients that can be affected in a positive way. So I'll leave you on that note and not go on to the whole DBS thing, which you'll have to say for me. Thank you.